right, let's see how many people we've got. Looks like 16 so far. So I guess while we're getting started here, or letting, the final folks join us, I'll do some introductions. So my name's Lindsay. This is my second presentation on the webinar, so hopefully I look familiar. I am the PGY2 Pharmacy Pain Management and Palliative Care resident at the Johns Hopkins Hospital. I'm actually presenting today from MedStar at Union Memorial Hospital in Maryland, so I did some traveling for a rotation this month. But my plan today is to talk a little bit about IV lidocaine for perioperative pain management. Kind of what brought this about is that at JHH we have had a policy in place for about a year now to technically allow use of intravenous lidocaine in the perioperative setting, but it's been inactive really through that time. And so this year we're updating our PCA library, and with that update we'll be adding IV lidocaine to our PCA cassettes. And so we anticipated that that's going to be something that gets used more frequently. And so I thought, in the spirit of that coming to our practice, I would talk a little bit about what data is out there to support the use of IV lidocaine in the perioperative setting, and then maybe compare it to IV ketamine, which is kind of thought of in a similar way in this setting. Now, I was told that we're aiming for more interactive webinars, so if you so if you have your video camera available, that'd be great. At least then it feels like I'm talking to some people. And if I'll ask kind of questions as we go through, and I'd love to hear from everyone your experience in using IV lidocaine in this setting, particularly, like I said, because this is going to be pretty new for us. We really don't see it. So before I get started, because it is 4:06 now, let me just ask the group, is IV lidocaine something that you are using at your institutions for perioperative pain management? Does anyone have any experience they could share with the group? Oh, it looks like got some response in the chat. I have an I wish, only on the acute pain service, and not sure. Okay, I'll take it. So, like I said, I'm gonna present some of this data today. What I've heard from other institutions, just anecdotally, is that, and maybe this is similar in a way to kind of how ketamine has gone at other institutions, if any of you are using that. But what I've heard is that once it became available, the acute pain services kind of ate it up and are putting everybody on it. So my goal is to kind of give everyone a little bit of background on when it could be useful and what sort of our expectations would be. So let's get started here, and hopefully my technology will cooperate. I'm not at my home base, so I'll do my best. Probably it's not a surprise to you, so this is just my disclosure slide. Pausing here was probably misleading. I have no relevant financial relationships to disclose. I will be talking about an off-label indication of IV lidocaine, and so that disclosure is here for you. And I don't plan to talk about the pediatric population. Here are my objectives for the talk. So first, we'll talk about the rationale for using IV lidocaine for post-operative pain at all. So many of us may have thought of IV lidocaine more classically as an antiarrhythmic agent. So it was first developed in 1943 and really being used for cardiac indications at that time. And then articles in the 1960s started coming out describing its use for analgesic purposes. And of course, lidocaine and other anesthetics have really taken hold in the anesthesia analgesia community since that time. So first, we'll talk about a little bit about why we think of IV lidocaine as a potential analgesic medication, and then we'll compare and contrast IV lidocaine and IV ketamine for postoperative pain management with the little data that we do have. So many of you may have, if you have heard of IV lidocaine being used for postoperative pain, you may have heard about it in the setting of early recovery after surgery, or ERAS. So ERAS was a protocol developed by a group of surgeons in 2001 and was meant to do a number of things to really promote recovery after surgery in an early sense, and they were aiming for quality outcomes as opposed to quantity outcomes. And so one of the big things that we talk about when we talk about ERAS protocols is opioids and just oral analgesics. And that's sort of where IV lidocaine tends to fit in. So one of the major barriers to recovery after surgery, as you can imagine, are opioid medications, right? They slow down your gut, they make you a little drowsy, they slow your recovery time in terms of neurologic recovery. And so the ERAS group really prioritized finding analgesic measures that could mitigate the use of opioids in hopes of promoting earlier recovery after surgery and avoiding complications that might prolong recovery in that setting. And so that's when we started talking about multimodal analgesia in a surgical sense. So NSAIDs, acetaminophen, and ketamine has a pretty clear role in the ERAS pathways. We also talk a bit about regional anesthetic techniques, and that's where systemic lidocaine sort of took hold and has become a little bit more popular now. So a little bit about its mechanism for analgesia. Lidocaine is thought to, classically at least, its mechanism is blockage of voltage-gated sodium channels. But we've learned through in vitro and in vivo studies that when you give lidocaine systemically as opposed to just topically, we think it has other mechanisms as well. So not only its sodium channel blockade, but also it seems to decrease inflammatory cytokines. And I've listed a couple of the key cytokines here for you. And then it can also modulate potassium channels, calcium channels, NMDA receptors, which of course makes us think a little bit of ketamine, and G-coupled protein receptors. So when it's given systemically, we think it has multiple mechanisms for pain control. But of course, its primary mechanism is interruption of neuronal signaling through the voltage-gated sodium channel blockade. When we think about using IV lidocaine, and this was kind of a hang-up point for our cardiology group, we think about a very different dosing regimen. So when it's used for pain, IV lidocaine is usually given in either a flat bolus dose of 100 milligrams or a weight-based bolus dose of 1 to 3 milligrams per kilogram. And then it may be started as a continuous infusion, and you can see the weight-based rate here. It's a little bit confusing, I think, for cardiology folks who are using this more commonly because the units that they tend to report are milligrams per minute, and they're not generally weight-based. So this looks a little different for them. It's also a much lower dose than they're typically using for its antiarrhythmic properties. So that'll kind of come into play and be helpful to think about as we're talking a little bit about monitoring and adverse effects and that kind of thing. But these are the doses that are commonly used in studies and commonly recommended for analgesic purposes. In terms of pharmacokinetics, it does have a relatively rapid onset of 45 to 90 seconds, but it has a biphasic half-life. So what that means is early on, lidocaine, its half-life ranges from 7 to 19 minutes. It's relatively short. But with continuous infusion, its half-life will prolong anywhere from 1.5 to 2 hours. And that's why when we talk a little bit about therapeutic drug monitoring, that biphasic half-life is what prompts us to get levels later rather than sooner, because it has this second this biphasic half-life where we have to wait for a second steady state to be reached. So that's something else that complicates its administration a little bit. In terms of contraindications, the patients we'd like to avoid lidocaine in, really it comes back to the biggest one that we think about is because of its cardiac toxicity and cardiac properties. We avoid IV lidocaine in patients with second or third degree heart block, or any patients with significant EKG abnormalities. And then it does have the tendency to accumulate in hepatic disease and renal disease, so we avoid it in those populations. And then there are patients who do have true hypersensitivities to anesthetic agents like lidocaine. So if patients fall into that category, this of course would be contraindicated for them as well. Okay, so therapeutic drug monitoring, again, this is another hang-up for our cardiology group, because for patients who are started on IV lidocaine and continuous infusion for cardiac purposes, they do require therapeutic drug monitoring. So I think our cardiac service, and I'd be curious to learn about other institutions where this is happening, if their cardiac groups are involved at all or had concerns when they had rolled this out. But typically, and particularly for analgesia, what I'll say is that we really don't have great data to guide or to correlate, I should say, serum levels with analgesic effects. And so when we're talking about therapeutic drug monitoring for lidocaine in pain settings, we're really talking about safety and not efficacy. So a level is not going to be real informative for us to know if the drug is working. Of course, that would require frequent pain assessment and some of our other measures we do to make sure our analgesics are effective. So when we're thinking about TDM for lidocaine for pain, we're really just thinking about safety. The recommendation, because of that biphasic half-life, is that levels should be drawn at 24 hours. So if a patient is on a continuous infusion, they should remain on that continuous infusion for 24 hours before a level is drawn. And then at the 24-hour point, that's when you would draw the level. So intuitively, that probably tells you that it doesn't make a lot of sense to get a level unless a patient is on the continuous infusion for at least 24 hours and ideally longer than that. And that'll kind of come into play when we look at the data supporting lidocaine, or, examining lidocaine for this purpose. Many patients are actually taken off of it at 24 hours or often even sooner. So not always something that comes into play. But when we think about toxicity, our kind of break point is 6 micrograms per milliliter, at least at Hopkins. At that point, that's when you can start seeing tonic-clonic seizures, unconsciousness, unresponsiveness. You can also see cardiac arrest, arrhythmias, and so usually 5 or 6 is the level where we start to become concerned. Not that I'll spend a lot of time going into it, but in the pain studies that did obtain serum levels for lidocaine, none of them got anywhere close to this. So typically, because that dose that we're using is much lower than the cardiac doses, we're really not getting into this territory, and so the adverse effects are pretty limited. So when we think about lidocaine monitoring for pain, really we're talking about, when we think about efficacy, we're thinking about regular pain assessment using a validated pain scale, because our levels are not going to be informative on the efficacy, and we also can't get a level until at least a day, and ideally sometime before 24 hours we've assessed their pain. So from a safety standpoint, we of course monitor vital signs, so respiratory rate, heart rate, blood pressure, and we would monitor for the emergence of any adverse effects, particularly those that we think about with toxicity of lidocaine. So lightheadedness, dizziness, perioral numbness is one that probably comes up when you're approaching that level of about 5, same with metallic taste and tinnitus. But there's a number of others that are listed here for you as well. So the next thing I'm going to get into is efficacy and some of the data supporting lidocaine for this indication. But I'll pause there before I go on, just to take if there are any questions or comments about any of the information that's been presented so far. Anybody have any thoughts, comments, questions, concerns? Okay, sounds like none, but please feel free to jump in. I'm not doing a good job of making this interactive so far, so feel free to encourage me. So I think because lidocaine, as we talked about, is a very, very old drug, there's lots of studies out there. And so we're going to talk about this particular systematic review that was done by Weibel and colleagues in 2016. It was a large review, teamed up with the Cochrane review group, and I think it reviewed the data points that I think are very helpful for understanding which patients might benefit from this, and which patients probably won't, maybe more importantly. So in this review, there were 45 randomized controlled trials published between 1985 and 2014. 43 of those trials compared lidocaine versus placebo, as opposed to 2 that compared it to thoracic epidural analgesia. We're going to focus on those 43 and not really get into the thoracic epidural analgesia for now. The lidocaine regimens that were used are listed here for you. The study, included about just under 3,000 patients, so a pretty big group of patients. And if you look at these regimens, hopefully they look relatively familiar to you. So that bolus is pretty much the same as what we presented earlier, the 100 milligram flat bolus or 1 to 3 milligrams per kilogram. And the infusions that were used ranged anywhere from 1 to 5 milligrams per kilogram per hour, which the 5 is a little higher on that upper end, but otherwise 1.5 to 2, it was fairly common through the studies. There were a few that reported their dose in milligrams per minute. If you remember, that's the dose that, or the units that cardiology typically reports for this drug, so that's why you see that. And I think a really important take-home point as we look at this data is to focus on the duration of the infusions that were used in the studies, because there was a pretty big difference, and because this will have a lot to do with how we apply this data moving forward. So most of the studies, like a vast majority of them, stopped the lidocaine infusion at 24 hours postoperatively or sooner. And in fact, there were only a handful that even made it to 24 hours. So many of the studies gave a bolus during surgery or gave an infusion, but ended that infusion at the end of surgery. Many of them ended it somewhere between 6, 8, or 12 hours after surgery. And a handful of them took it to 24 hours post-op, and then 1 or 2 of them took it to 48 hours post-operatively. So most of the data that we have for lidocaine in the surgical setting really is in the immediate post-operative period. And I think that that's another important take-home as we start thinking about how this would be applied, because of course, if we compare that to how we're used to seeing ketamine, for those of us that are using a good bit of that, ketamine will stay on for days after surgery, and so this is very different. So I'm going to walk through the data from this systematic review. We'll start with the pain outcomes first. So what you see here is the change in visual analog scale for all procedure types, so any type of surgery, and it's broken down by time from surgery. So the early postoperative period was considered to be that first 1 to 4 hours after surgery. The intermediate period was up to 1 day or 24 hours postoperatively, and then late being 48 hours post-op. I have the number of studies here for you and the number of patients receiving either intervention. And what you can see is that, hopefully my red boxes work, yes, is that the data is not really profound. So we did see a statistically significant difference in the early and intermediate postoperative periods, and this is the confidence interval here in the brackets. So you can see in the early postoperative period, we had a mean change on the visual analog scale of 0.8, an improvement of 0.8 in patients' pain in lidocaine compared to placebo, and that confidence interval does not cross 0, so it was statistically significant. We also had a lower statistically significant difference in visual analog scale in the intermediate time frame. But then once you get to 48 hours postoperatively, it is no longer a statistically significant change in patients' pain scores, and you could argue the clinical significance of any of these differences. So I think the first take-home point I'd like to make is that the small difference in pain that we do see with lidocaine postoperatively really kind of tapers off at the 24-hour mark postoperatively. Next, I want to break the outcome down by surgery type. So this review looked at laparoscopic abdominal surgery, open abdominal surgery, other surgeries, and then I also included the overall numbers just for the sake of comparison. So looking first at the mean change in the visual analog scale among these procedures, what you'll see is that laparoscopic abdominal surgery had the most profound difference in visual analog scale. Now, albeit, again, the clinical significance of it we could discuss, but that's where we saw the greatest magnitude of difference in visual analog scale. And it was the 2 types of abdominal surgeries where this difference was statistically significant. So for all other surgery types, and it was not a statistically significant difference in pain scores. So this makes us think maybe it's our abdominal surgery patients where we know they're likely to have highly severe pain postoperatively. Maybe it's that group that is likely to benefit the most from this intervention. Other surgery types didn't seem to have a statistical difference. And then overall, there was a difference in visual analog scale in all surgery types, so I included that here for you. But again, that was really driven by the abdominal surgeries. What you'll also see is that their opioid requirements followed a similar trend. And so the laparoscopic abdominal surgery had the most greatest magnitude of change in opioid requirements. This was IV morphine equivalents, so a difference of 7 IV morphine equivalents in the 24-hour postoperative period. And that was statistically significant and really was across all of the groups, but the greatest magnitude of difference was in the abdominal surgery group. So they achieved better scores, better pain scores with less opioids. And so I think that's the takeaway there. Is it a profound difference? No. The next thing we'll look at just briefly is recovery measures after surgery with patients who received IV lidocaine versus placebo. So in this group, they were looking at postoperative ileus, time to first bowel movement, time to first flatus, and duration of stay. And so what you'll see, again, starting at the top with postoperative ileus, we see just by a hair, statistically significant reduction in postoperative ileus. Moving down, we see a slight reduction, but statistically significant reduction in time to first bowel movement, in time to first flatus, and a slight difference in duration of stay. And so really this slide is what encompasses why IV lidocaine gets a lot of attention for postoperative pain, particularly in those ERAS pathways, is because across the board, albeit in a modest sense, it is providing statistically significant improvements in many of our recovery outcomes. And likely that's because it has the ability to reduce opioid requirements postoperatively. Okay, and then lastly, postoperative nausea and vomiting is something that they looked at as well. Again, both of these were statistically significant. Clinical significance here is maybe questionable, but we did see a statistically significant improvement in postoperative nausea and vomiting, both in the PACU and within 72 hours postoperatively. And so again, likely the authors at least attribute this, and I think as a medical community, we attribute these effects to lidocaine's ability to at least modestly reduce opioid requirements after surgery. So, that's my poll everywhere slide. We can use this question. So I'll ask the group, hopefully you took away the right things. Hopefully I did a good job communicating which of the following accurately describes the rationale for using IV lidocaine for acute pain. So the first option would say that lidocaine produces a profound and a prolonged reduction in postoperative pain. No, I'm going to call on Lauren because I know Lauren. Lauren, can you tell me why it's wrong?
Because it doesn't cause a profound or prolonged. Both of those are actually wrong, but it does have a difference.
Thanks. Okay, great. Yeah, so profound is obviously a very strong word to use to describe lidocaine's effect on pain after surgery. I wouldn't call it profound. I also wouldn't call it prolonged, as we saw that those effects started to taper off at around the 24-hour postoperative time mark. The next option says that lidocaine may improve postoperative pain control compared to standard management. So what do we think about that? Yeah, I agree. I'd give it one of these, like, yeah, maybe, kind of. And then option C says lidocaine reduces postoperative opioid requirements and improves recovery after surgery. What do we think about that one? Do we think that lidocaine has the ability to maybe reduce postoperative opioid requirements? I'm seeing unsure looks. So I'm going to go back just really quick, just so we are all on the same page before we move forward. So that's this last box here. Again, we can argue clinical significance a little bit, but looking at all of our different surgery types. So abdominal surgery had the greatest effect, but other surgeries and overall, we did see a statistically significant reduction in opioid requirements postoperatively. This is in the 24-hour postoperative period. And so I think we can say that the first part of that statement was that lidocaine has the ability to reduce postoperative opioid requirements. And I think that's true. I think that's a fair statement. The second part said that lidocaine improves recovery outcomes after surgery. And I think we can say that that's true too. So In this systematic review of about 3,000 patients, they found a reduction in postoperative ileus, a reduction in time to first bowel movement and first flatus, and actually a reduction in duration of stay as well. Now, again, clinical significance can be discussed in all cases because these are modest changes, but ultimately, bump through. Oh, I think our option C here, which says it can reduce opioid requirements, improve recovery after surgery, I think that's also a true statement. So the correct answer for this slide would be B and C. So it may improve pain management, and it does tend to reduce opioid requirements after surgery and ideally help patients recover quicker. So again, before we move on, I'd like to pause. I don't know if anybody's joined us since I asked in the beginning, but I'd love to know if there are any institutions out there that are using lidocaine or whose pain services are using lidocaine in the postoperative setting. I'm curious how they're using it, because I think our concerns at JHH are that the data really doesn't support using lidocaine in every single patient all the time for many days on end. And, you know, I think many of us as a community of pain providers have seen a similar trend with ketamine, that ketamine gets started on many of our acute pain patients and gets kept on for some time. So I'm curious, does anyone have any insight into how long lidocaine is being used, how often it's being started? Seeing some head shakes, and we can use the chat as well. I don't know, looking through to see if there's anyone that I know well enough to call on.
Hey, Lindsay, can you hear me?
I can.
Okay, it's Maria, you stole my webcam, so you can't see my face.
Oh, hi, Maria.
Hey, but our group, actually one of my residents, the PGY1 residents, did a drug use evaluation on ketamine specifically in the post-op period, not lidocaine, so I can't comment specifically on lidocaine, but what we were seeing with ketamine, and I would assume that it's similar to lidocaine, is that 24 hours, if patients made it on ketamine for 24 hours, it was lucky. What she found was that the majority of patients who were started on post-op ketamine, they were probably started, they're using it like water, our acute pain services, so maybe inappropriate and appropriate uses, but a lot of them had to discontinue it due to adverse effects, I think, because they are using it way too willy-nilly. So I would assume that lidocaine is similar, that they're stopping it at 24 hours, not particularly for side effects, but I can't imagine that our patients are hanging on with IV lidocaine too long, at least I hope, which then maybe they are getting the benefit given the data that you presented, but I can't comment, but I'd be curious, so now you piqued my interest. Might be another DU.
Good, I'll be glad if I inspired another project. But yeah, I think that's an interesting point. And when we talk about ketamine a little bit, we'll talk at least about some of the dosing limitations. We at JHH, we cap the dose that they're allowed to use on the floors, and it's a relatively low dose for ketamine. And so we tend to have patients who are on ketamine for upwards of like 4 or 5 days a lot of the time. Post-operatively, but I don't know if maybe they're tolerating it a little bit better just because we do cap that dose. Now, of course, you could argue efficacy then too. But yeah, I think that's really interesting to hear about, and potentially is something we'll run into with lidocaine too, because the dosing range is fairly wide, and if you start getting up into those upper numbers that are closer to the cardiac doses, I could see that patients would start having side effects. Many teams hopefully won't want to deal with the therapeutic drug monitoring, and so then they'll take them off at 24 hours. Does anyone else have any experience that they can share or any insight into any of this? Okay, I'm hearing none, but the chat is here. Please feel free to chime in or share your experiences. So I think just some take-home points from my standpoint about thinking about IV lidocaine post-operatively, because if it hasn't come to your institution yet, maybe it'll be at an institution near you soon. So some kind of things to keep in mind is that this is not a drug that has a lot of data to support its use beyond the 24 to 48 hour time frame. In terms of its effect on pain management and opioid requirements, the data suggests that the magnitude of its effect is modest at best. And then if you're going to keep the patient on it beyond the 24-hour mark, it is recommended to monitor levels. And for some institutions, that's a send-out level, the lidocaine levels. So that's something else to consider. And then lastly, when you're thinking about populations that might get the most out of this drug, it's really the abdominal surgery patients who we saw the greatest benefit in reducing pain scores, the greatest benefit in improving reducing opioid requirements. So maybe abdominal cases make sense if patients don't have some of those contraindications. So the next kind of portion of this talk, I was hoping is to compare and contrast lidocaine with ketamine and see if there's any data to guide us, because now that we have this other non-opioid IV medication that might reduce opioid requirements, the lingering question is then, so do we use both? Should we use one over the other? If we're using one over the other, what guides that decision? And so that's what I wanted to focus on in the next half of the final third, I guess, of this presentation. So IV ketamine, the doses here that you see are our dosing guidelines at JHH, and probably a little bit different than other institutions. So there's the option to give a bolus that's weight-based, and then most of the time, ketamine is a continuous infusion. The range of dosing is here for you. At our institution, most of our anesthesiologists are starting it at 0.1 milligrams per kilogram per hour. And then that dose maxes out at 20 milligrams per hour, where many studies, particularly chronic pain studies, use it at a higher rate than that, and many institutions end up exceeding this 20 milligram per hour limit. That's when we tend to see some of those, at least psychiatric side effects, is at doses above that range in particular. Of course, you can see it across the dosing range, but they're most profound at doses greater than that. And I'll say, at least in my brief experience with our acute pain service, they're usually not even getting them up to 20. So I would say most of them stop somewhere around 14 milligrams per hour for fear of side effects. So those are the dosing limitations that we use at Hopkins. Be happy to hear what other institutions are doing. In terms of PK information, that's listed here for you. So quick onset, short duration of action. In terms of its immediate analgesic effects, its half-life is very short. We do think of ketamine as, or at least a lot of our anesthesiologists kind of sell it as this reset button for your mu receptors. So they think that in resetting your mu receptors or making those maybe more responsive to opioid medications, that the effect of ketamine may outlast the actual duration of the infusion itself. So that's sort of how our anesthesiologists talk about it a little bit. In terms of relative contraindications for IV ketamine, we tend to avoid it in patients with heart failure, coronary heart disease, pulmonary hypertension. We are also avoiding it in patients with high ICP or intraocular pressure, in pregnant patients, and then patients with a history of active psychosis or a history of schizophrenia, we tend to avoid it because of the psychiatric emergence side effects. And then lastly, in severe hepatic dysfunction, we're avoiding IV ketamine. In terms of adverse effects, we tend to see the opposite with ketamine in terms of hemodynamics that we're used to with lidocaine. So where lidocaine may cause a drop in blood pressure, ketamine actually tends to increase the blood pressure, increase the heart rate. And so for that reason is maybe helpful in the perioperative period, intra-op in particular, just to maintain blood pressures, but can be also something that's detrimental to your patient depending on where they kind of sit in terms of blood pressure. It can also cause some respiratory depression, much less so than IV opioids, for example, but it can produce respiratory depression. It also can cause hallucinations, extreme dissociation, psychiatric emergence, and so I think that's something we see a lot in our chronic pain clinic where we're using it at much higher doses. It can cause some hypersalivation and some of the other things that are listed here for you. So Maria, I may come back to you in a couple of minutes, and I'd be curious to know which adverse effects were most problematic for you guys, but I'll hold off for now. So these recommendations come from the acute pain guidelines that came out in 2018. Those guidelines said that we should think about ketamine in these 3 clinical scenarios. So for surgeries that are expected to produce severe pain, they gave us a grade B moderate certainty recommendation to consider the use of IV ketamine. And they considered those surgeries to be abdominal surgeries, thoracic surgeries, and orthopedic surgeries, so limb and spine. Hopefully you're thinking, well, Lindsay, you just told me that lidocaine can be used for the abdominal surgery population. So you can see the dilemma here. We really don't have a good way of delineating in terms of surgery type which one would be more beneficial. So that's a little bit of a gray area. We also think that ketamine might be helpful for patients who are opioid tolerant or dependent already and planned for surgery. That's another grade B recommendation, though it was low certainty. And then for patients with sleep apnea because of its lower propensity to cause respiratory depression, but that was a grade C recommendation. So these are the places that our guidelines tell us to think about ketamine. And so as you're probably thinking, those considerations really aren't that different from what I told you about when to think about lidocaine. So the next step was, let's see if there's any research out there comparing the 2 drugs in the perioperative period to guide us on which one might be better. The answer is there's not much out there, and the studies that are out there are are poorly designed. So 2 of the 3 randomized controlled trials that I was able to identify, I ended up excluding because the primary outcome in the first study was 6-minute walk distance and functional outcomes, not really pain, and more importantly, the study design really limited my ability to make a meaningful conclusions. And then this 2019 study studied only intraoperative use of IV lidocaine, and for my purposes, I was trying to compare and contrast the use of these 2 agents postoperatively, and it also had a unfortunately poor study design that made it hard to understand how to apply the data to other populations. So I excluded those 2, and we'll focus on this study by Jen Dubey and colleagues from 2017. So this study looked at patients who are undergoing elective open nephrectomy. To be included in the study, they had to be older than 18 years old, they had to be undergoing the elective open nephrectomy, and they had to be relatively healthy. So this ASA physical class 1 or 2 is, generally speaking, relatively healthy individuals. They were excluded from the study if they had any allergy to the study drugs, if they weren't able to be taught how to use a PCA, if they had markers of liver or renal dysfunction, or heart failure with an ejection fraction less than 30%, if they had an ASA physical status greater than or equal to 3, so they were very ill, or, and probably most importantly, they excluded patients with a history of chronic pain, chronic use of opioids or alcohol, and drug abuse. So at least for us here in Baltimore, but I'm sure obviously this is a national epidemic, that pretty substantially limited our ability to limits our ability to kind of extrapolate this data, because of course those are the patients that were most interested in potentially limiting their postoperative opioid use or finding alternatives. So something to keep in mind. Just so you have the dosing information, in the lidocaine group, they were given a bolus of 1.5 milligrams per kilogram, and then that was followed by a 1 milligram per kilogram per hour infusion, and the infusion was continued for 24 hours postoperatively. So they stopped it at 24 hours post-op. And then in the ketamine group, they got a 0.15 milligram per kilogram bolus, and then they got an infusion of 0.1 milligrams per kilogram per hour for 24 hours postoperatively. I think one thing to keep in mind is that, of course, we don't have equianalgesic dosing for these 2 different drugs. That wouldn't really even make sense. But in terms of the dose for ketamine, this is on sort of the lower end of the allowable dosing range for ketamine for analgesia. And for lidocaine, it's a little bit more mid to upper dosing. So something to keep in mind as we look at the data. The pain management protocol that the study used included IV acetaminophen and this drug IV nefapam, which actually is kind of like an SNRI. They were given that intraoperatively, and then in the PACU, they could get IV morphine, 2 milligrams every 5 minutes until they had a visual analog scale less than 3. And then a morphine PCA without a basal infusion, they could use 1 milligram boluses with a 7-minute lockout. Once they got to the surgical ward, they were, in addition to whatever IV drug they were getting, they were also given acetaminophen, 1 gram Q 6 hours around the clock, and this nefapam, again, 20 milligrams IV Q 8 hours around the clock. And again, that's kind of like an SNRI. The primary outcome in this study was cumulative morphine consumption over the 24-hour postoperative period. So they were looking primarily at how much opioids were used postoperatively. They also, as secondary outcomes, looked at some pain-related outcomes, the number of patients requiring morphine titration in the PACU, pain scores at rest and during coughing. They used this Douleur Neuropathique 4 questionnaire, which was kind of an interesting outcome to use. It was a questionnaire that they sent out to everyone in the study at 3 months postoperatively, and it was meant to assess the development of postoperative neuropathic pain, chronic neuropathic pain after surgery, and so that was kind of an interesting one. And then they also looked at some recovery-related outcomes. So they looked at opioid-induced side effects, adverse effects of whatever intervention drug they received, recovery of valve function, and functional capacity through a 6-minute walk distance. So this is what the population looked like at baseline. There were 20 patients in each group, so 60 patients total. No statistically significant differences between the two groups in terms of their age, their sex, their BMI, and their baseline ASA physical status. The indications for surgery are listed here for you, pretty consistent across the board. Their duration of surgery was reported on. I think that's helpful to have that information, and their intraoperative fentanyl and fluid utilization. So no major differences in these baseline outcomes. You'll have to bear with me a little here because this study provided very few, did very limited reporting of their actual outcomes. So this graph is one of the only things that they put in their study to report on their primary outcome. So I tried to make it as readable as possible for you. I'll orient you a little bit. On the y-axis here, you have cumulative morphine consumption, and on the x-axis, you have postoperative hours, so the number of hours since surgery. The black line is the control group, the red line is the ketamine group, and the blue line is the lidocaine group. And so in this graph, the asterisks are meant to represent statistical significance at that time point. So looking at this graph, what you can see is in terms of comparing either group to placebo, both of them had a statistically significant reduction in cumulative morphine consumption compared to the control group. So both were effective through hour 24 in reducing opioid requirements. In terms of differences between the two of them, at 24 hours post-op, there was really maybe about a 5 milligram difference in IV morphine between the two groups. And pretty consistent all the way through maybe post-operative hour 12 is when they start looking a little different. On this graph, we have one added symbol that I'll explain to you. So at the bottom of the graph, you'll see, I don't know what the symbol is called, but it's like a cross with 2 hashes across it. That symbol is meant to represent when lidocaine versus ketamine is statistically significant. So our asterisk is either treatment group versus control. The cross thing is lidocaine versus ketamine and statistical significance at the time point. So here we have visual analog score at rest and postoperative period in hours on the x-axis. What you'll see if we compare both groups to control, both groups were able to statistically significantly and clinically significantly, arguably as well, improve visual analog score and pain scores all the way through hour 24. At hour 48, that difference is no longer statistically significant for either drug. And then when we're looking at comparing lidocaine and ketamine, again, ketamine's the red line, lidocaine is the blue, what we see there is that there is also a statistically significant reduction in visual analog score with lidocaine compared to ketamine through about hour 12. And if we're talking about clinical significance, like a 2-point drop on the visual analog scale, that probably tapers off around hour 6. But in the early postoperative period, lidocaine actually did confer some benefit in terms of reducing visual analog scale. So in summary, between these two graphs, both study drugs were able to improve visual analog score at rest compared to control with less opioids. And lidocaine maybe had a slightly more profound reduction in visual analog scale with about the same amount of opioids compared to ketamine. In terms of recovery outcomes, I'm sorry, this is a very busy slide. Hopefully by the p-values that are all less than 0.0001, you can see that there is some statistical significance here. We'll talk first about bowel function. What you see under bowel function as their outcomes were time to first meal, time to first flatus, and first defecation time. And when we compare control group to lidocaine and the control group to ketamine, we found that both drugs provided a statistically significant reduction in these outcomes as compared to control. So both were better than our standard management. What you'll see next is with 6-minute walk distance, again, is that, and again, this is comparing either drug to control. We're going to compare the two drugs to each other in the final column. So hopefully you're all following me here. With 6-minute walk distance, we saw that lidocaine conferred a statistically significant reduction or improvement in 6-minute walk distance as compared to control. Ketamine had a numerical improvement in 6-minute walk distance, but the result was not statistically significant. Lidocaine is the one that had a benefit here. When we look at duration of stay, both drugs improved duration of stay as compared to control. And the DN4 score, which is our measure of development of chronic neuropathic pain postoperatively, we saw that lidocaine had a statistically significant reduction in the development of chronic neuropathic pain after surgery versus ketamine, which was not significant. They did not record a p-value for that outcome. So then when we look at lidocaine versus ketamine, what you can see is that lidocaine across the board was improving these recovery outcomes in a statistically significant reduction compared to ketamine for all of the recovery outcomes that were reviewed. Probably most interestingly is looking at this DN4 score. So of all the 20 patients, only 1 in the lidocaine group screened positive for the development of neuropathic pain postoperatively versus 7 in the ketamine group and 9 in the control group. So that was maybe the most substantial difference. But lidocaine was the one that really conferred the most benefit here in this study. So we'll talk just briefly about strengths and limitations. I think some of the strengths of this study, especially when I compared it to some of the others that were out there, is that it did use a standard procedure type, so everyone was having elective open nephrectomy. They did compare functional outcomes among treatment groups, which we've learned is kind of the driver of IV lidocaine use. And they did assess postoperative neuropathic pain, which I thought was just an interesting outcome to look at. In terms of limitations, though, I think one significant limitation is our ability to compare dosing. So it's hard to really know how these outcomes would be different if a higher dose of ketamine had been used, for example, because we know they certainly weren't at the max dose of ketamine, weren't at the max dose of lidocaine for that matter either. So I think it's a little difficult to compare the dosing of these two very different agents. The duration of infusion is limited to 24 hours postoperatively. The reason I put that as a limitation is because it limits our ability to apply this data beyond the 24-hour point. So keep that in mind as you're using this data to guide your practice. They provided very limited data. Like I said, those two graphs that I showed you were about it in terms of reporting on their primary outcome. So it's a little difficult to interpret some of the data that they provided, and so that limits us a little bit. It was a relatively small sample size with only 60 patients. And they did exclude patients with prior opioid use, which makes it tough to generalize to our populations. However, at least in terms of key findings from this study, we can say that lidocaine and ketamine both reduced postoperative opioid requirements statistically significantly and provided a clinically meaningful analgesic benefit following open nephrectomy. So at least for this particular surgery type, they both achieved more with less opioids, which I think is always the goal. Keeping in mind, however, that this effect that we saw was really limited to 12 to 24 hours postoperatively for both drugs. And then At least in this study, lidocaine was more effective than ketamine for improving recovery outcomes, interestingly, after surgery. However, you know, this is in one single, very small population, and so this is something that I think needs to be studied more rigorously before we can draw any conclusions. But at least in this study, that's the trend we saw. So in conclusion, perioperative use of IV lidocaine, as we've talked about, really is gaining traction because of its ability to promote earlier recovery after surgery by potentially reducing postoperative opioid requirements. It's certainly not that it produces a profound difference in pain management and pain scores after surgery, and there are significant limitations in terms of the populations to which we can apply that data. In terms of comparing lidocaine to ketamine in the perioperative setting, we have very limited data to guide us, and so in the lack and without much data to guide us, I think we have to use our clinical judgment. So things to consider are the adverse effect profile of these drugs, contraindications, patient comorbidities, also bearing in mind that lidocaine requires therapeutic drug monitoring. So I think that's where we're left kind of with that. It looks like, Chris, you're maybe talking, but I can't hear you if you are trying to. I'm going to keep going. If you have anything to say, throw it in the chat. So this is our last question. This is a patient who's 56 years old. They have a past medical history of poorly controlled hypertension, hyperlipidemia, schizophrenia, and diverticulitis. The patient's going to go to surgery on Friday for an open abdominal surgery. And so your team is asking which perioperative analgesic would be preferred for this patient and why. So our first option, I think this is a typo. It's supposed to say ketamine is preferred because it produces profound and prolonged analgesia compared to lidocaine. So that's supposed to say lidocaine. Sorry about that. Does anyone have any thoughts on that? Do we feel like that's true or false? You can also feel free to use the chat if you'd like. Oh, whoa, sorry. Oh, I see some other people use the chat and I missed it, so I'm going to come back to that stuff. Thank you all for chiming in there. Okay, so we'll move quickly so I can get to these comments then. Ketamine, hopefully you learned from our study, is not producing profound and prolonged analgesia as compared to lidocaine. In fact, in the one study that we have to compare the two, lidocaine actually performs slightly better. Option B says that ketamine is preferred because it provides superior analgesia and may treat his schizophrenia. Hopefully nobody thinks that that is the right answer. Ketamine certainly can exacerbate schizophrenia and psychosis through psychiatric emergence. Option C says that lidocaine is preferred because ketamine lacks data to support its use in abdominal surgery. And that's also not true if we remember the acute pain guidelines suggest abdominal surgery as one potential surgery when we should consider ketamine. We also have data to suggest we should consider lidocaine, so that's not the right answer. And then lastly, lidocaine is preferred given this patient's history of poorly controlled hypertension and schizophrenia. That would be the correct answer. And really the hope here was to prompt you to think about the adverse effect profile, the contraindications of these drugs when really trying to figure out their place in therapy. So that is all I have. I can't figure out how to go to the next slide. There we go. So I see some stuff in the comments, and you may, in order to speak up, I don't have the ability to unmute you guys, but you may on Zoom have to unmute yourself, even if your phone or computer is not muted to speak. But I see some people chiming in. I'd love if you would want to address the group.
This is Jess. I'm not sure. Can you hear me?
I can.
Oh, cool. So that was my comment on the ERAS protocol. So I was in some of the discussions when they were going through some of the data for lidocaine, and they had one physician who was using it, and then the rest were trying to find a protocol to help them know who to use it for. But I wasn't there for their go live, so I don't know how that went when I left for my PG by 2. But my research was on ketamine after abdominal surgeries. Very small sample size, so we only had 19 patients that we could include. So working on that manuscript.
What did you find out? What did you find out in your study?
So we found that actually since it was retrospective, we couldn't control when ketamine was started, and it had to be started within 24 hours post-op. And because some of those patients started so late in that 24-hour period, we found the best benefit in that 24 to 48-hour period, which kind of correlates to the first 24 hours of ketamine use when you look at it that way. But that's when we saw the best benefit on opioid requirement reduction.
Okay. That's helpful. Thank you. And thanks for sharing.
Yeah, no problem.
Is Brett still on the line? It looked like someone named Brett chimed in. It looks like you are, Brett. You might have to unmute yourself on Zoom. Thanks. Well, I will read what Brett said. And Brett, if you have a chance to speak up, that would be great. If not, no worries. So Brett said that at his institution, the acute pain service has started to use both as appropriate in intra and post-op in thoracotomy cases up to 24 hours. Surprisingly, there's been some fairly good results. Had a couple of people barely touch a hydromorphone PCA. That's great. That's great to hear. Interesting that they went for the thoracotomy cases. Oh, it sounds like Brett's office is noisy. Thanks for commenting. That's totally fine, and thanks for sharing that. Does anyone else have any other experiences, questions, thoughts, anything they'd like to share? Okay. It sounds like no.
Hey, sorry, can you hear me?
Go ahead. No. Yeah.
Okay, my name's Dale. I'm a PGY2 resident at UC Davis Medical Center. And over here at UC Davis, IV ketamine has to be used in the ICU setting. So we actually, sometimes if the patients are floor patients, whether it be post-op pain, cancer pain, or just difficult to manage pain, we use oral ketamine. And I was wondering if that's something that other institutions use, or it's more unique to us.
Are you compounding it as an institution, or where are you getting it?
Yeah, we just use the IV mixture and then dilute it.
Gotcha. Yes, we don't do that. At least I'll speak for Hopkins, and then yeah, I'd be curious what others are doing. We don't use a ton of the oral ketamine. We have a lot of patients on the IV ketamine, and then as a sort of down titration measure, our institution is using a lot of actually dextromethorphan. They used to do with the oral ketamine and kind of chase it with something else. But once some of this data came out for dextromethorphan, they've started using that and gotten a little excited about that, although that data is not real substantial either. Does anyone else see use of oral ketamine at their institutions? Brett says oral ketamine is used at his institution as well, 10 milligrams every 6 hours, often on opioid tolerant or history of IV drug use. Awesome. Interesting.
And Brett, is that normally for post-op pain or any sort of pain?
Acute pain service, mostly the ones using, sometimes palliative. We've tried it a few times in chronic pain folks. Haven't been overly excited for CRPS. Yeah.
All right,
yeah, our
thank you.
chronic pain team uses it a lot. No, thank you for sharing. Our chronic pain team uses the dextromethorphan a good bit. We do have a couple of palliative patients that we've sent with oral ketamine compounded in the community, but not as often. Had good luck with intranasal for SUNCT syndrome. That's interesting. We've had a lot of discussion about intranasal ketamine recently here as well. Not a lot of rollout, like not a lot has happened with it yet, but that's interesting. Anyone else have any experience that they can share? Well, thanks so much to those of you who did share. Thanks for everyone for tuning in. If anyone has any questions, feel free to ask or shoot me an email. It was great having everyone here to listen. Thank you.
Great job.
All right, bye, everybody. Thank you.